has been the lead technical provider to establish and support integrated networks to deliver new models of care that address medical risks and social determinants of health, supporting value-based contracting in 26 states. And we are very happy to have him here. The next voice you will hear will be Mr. Tim McNeill.
Great, thank you so much. It's a pleasure to present to you all. And so I have quite a bit of content, and I'm happy to field questions as we go along. So feel free to post questions in the chat or raise your hand if there's anything in particular that you want additional detail on. And then we'll have additional time for question and answer at the end, hopefully. And so today I'm going to do a deep dive into new rule changes that allow for reimbursement to address health-related social needs. But first, I want to dive into the context upon which these rules are being laid. So we're going to jump into some of the regulatory changes that I think you all should be aware of, and then we'll go into the actual changes in payment policy. Next slide. And so as context, in 2023, there were significant changes and regulatory changes that require aspects of the healthcare system to screen and document health-related social needs. The first one was in 2023, NCQA that accredits over 90% of all health plans made a new HEDIS measure requirement for health plans with NCQA accreditation. And it requires all health plans with NCQA accreditation to begin screening for health-related social needs in 3 categories: food, housing, and transportation. And then in addition to screening, the second bullet in the middle that's highlighted in bold, they also have to report the percentage of members that screen positive for a health-related social need and receive a corresponding intervention within 1 month of identifying a need. So now 90+% of all health plans are mobilizing to screen their members for health-related social needs, and they have to document if those persons receive an intervention if they screen positive. And failure to do so will cause those health plans to have a poor rating on this HEDIS measure. Next slide. So while NCQA accredits 90+% of health plans, Joint Commission accredits 90+% of hospitals. They also enacted a 2023 requirement that requires hospitals, as part of Joint Commission accreditation, to screen for health-related social needs and link persons to community resources to address those needs. So you see the theme, both health plans, health systems, there's this new accreditation requirement to screen and find linkages to community resources to address those needs. Next slide. Now, this is a CMS rule change. So CMS pays hospitals, for the hospitals and organizations who work with hospitals on the line. There's something called the Inpatient Prospective Payment System Rule, or IPPS rule. And this is how hospitals are reimbursed. And this rule change states that hospitals now have to screen for health-related social needs in 5 different categories, and they have to report them. But different from NCQA and Joint Commission, CMS has the authority to apply penalties. So they are going to begin applying a financial penalty to hospitals that fail to screen and report social needs amongst the population. And this screening, even though this is a CMS rule, hospitals to be compliant have to screen everyone over 18 that's admitted to the hospital and document what their social needs are. And so the concern was, if there's this major escalation in screening for social needs, most likely we're going to find many more needs than we knew were there. And there needs to be a mechanism so that we can take action on those health-related social needs. Next slide. One way to assist hospitals with taking action is in payment policy. And it did, so CMS for the first time now recognizes homelessness, both sheltered homelessness and unsheltered homelessness, as a complicating comorbidity on an admission, which means that a hospital will receive a 3.1% increase in their MSDRG reimbursement simply by reporting homelessness as a complicating condition. This is really significant because it's the first time that CMS is going to provide additional reimbursement when there is the presence of a health-related social need, starting with homelessness, and they left the door open to adding additional social needs in the future. So if a person's admitted with a diagnosis of diabetes, and then the hospital adds to the diagnosis list sheltered homelessness or unsheltered homelessness, then that is counted as a complicating comorbidity on the admission, then the hospital would receive an additional 3.1% increase in reimbursement, even if they don't do anything. But ideally, they are receiving this additional reimbursement, not to address the homelessness, but they're receiving this additional reimbursement because there's a recognition that the presence of homelessness is going to complicate the discharge plan. And so therefore, the hospital is going to receive additional reimbursement because the complexity of the management is increased. Next slide. So there's evidence that supports the creation of health benefits to address health-related social needs or social determinants of health. And then I'm going to go into what these new benefits are. Next slide. So there's something that's called the Accountable Health Communities, which was a 5-year demonstration that CMS, there's actually the Center for Medicare and Medicaid Innovation, which is part of CMS, that they implemented. And it was the first of its kind demonstration to screen Medicare and Medicaid beneficiaries for health-related social needs and then provide them with navigation to address those needs. The demonstration ended in 2021. And the second evaluation report was released in May of 2023. And this really provides a foundation as to why CMS thinks that it's important for providers to not just screen and identify social needs, but actually take action on those because there is a true potential financial benefit. Next slide. So there were over 1 million participants in this CMMI demonstration over 5 years. And the evidence showed by screening for social needs and then providing navigation services to address those needs, that there was a statistically significant outcome of a reduction in ED visits, reduction in avoidable ED visits across both Medicare and Medicaid populations. And this was a statistically significant outcome that there was a true reduction in costs. Next slide. The additional data from this, and again, this is with over 1 million participants in this demonstration, it found that there were particular groups that had greater impact on their total cost of care than others. So on the left-hand side, we found the data showed that amongst non-white or Hispanic participants, that the impact on addressing their health-related social needs led to significantly less unplanned readmissions, reduction in total admissions, and a reduction in total expenditures, and that was greatest amongst that population. On the right-hand side, the data showed when persons have more than one health-related social need, the financial impact in screening to address those needs was far greater the more needs that they had. Next slide. So now we've kind of set the stage where there's regulatory policy that is causing a massive increase in screening for health-related social needs across health plans and health systems. In addition to that, the evidence shows that addressing those needs or attempting to address those needs will have a true financial benefit. That laid the stage for CMS to establish new payment policy, which is the first of its kind direct payment mechanism for simply addressing the health-related social needs of a beneficiary. Next slide. So this is really a landmark rule. It is a final rule. It's not a demonstration. It's not a one-time thing or executive order. It is a final rule where there's a permanent benefit in the Medicare program where it provides a direct pathway for reimbursement for labor to address health-related social needs. And that labor can be delivered by community health workers, but it's not only for community health workers. The labor could be health coaches, navigators, and others. This rule went into effect January 1, 2024. So it is a live benefit right now. And is because it is a Part B benefit, all Medicare beneficiaries have this benefit on the books. In addition to that, all Medicare Advantage and special needs plans also have a statutory requirement to cover all Part B benefits. So now just really think broadly, all persons in Medicare, all persons at a Medicare Advantage. If you think about dual eligible special needs plans like United Healthcare Dual Complete that's operating in all three markets, Maryland, DC, and Virginia, all of those beneficiaries have this benefit on the books right now. In addition to providing reimbursement to traditional providers, there is a direct payment pathway for federally qualified health centers and rural health centers under this benefit as well. And I'll provide more detail on the structure of the benefit. Next slide. So just to give some context of the number of people that are impacted by this rule. So as of April 2024, there's 66.7 million people that are eligible for Medicare. And now this 66.7 million people across the country have a benefit on the books to address their health-related social needs and need to take advantage of it. Next slide. So there are three categories of codes, and I will provide details about each of them. And this table provides the outline, and then I'm going to give you examples on what's required to implement. So the first column where it says community health integration. So we start there, then we'll go to the middle column, and then the one on the far right. On the first column, community health integration. That is the benefit specifically for providing reimbursement for the labor to address the health-related social needs of a Medicare eligible beneficiary. The personnel that can provide that are auxiliary personnel working in with a relationship with an eligible provider. The auxiliary personnel that would qualify include community health workers, health coaches, social workers, and other staff with applicable training. The eligibility criteria for the community health integration benefit is that that person must have at least one health-related social need, and that health-related social need must be documented in the electronic medical record. In the middle column is another benefit that also started January 1. All of these started January 1 as permanent benefits. And this one's called Principal Illness Navigation. And so CMS felt that the evidence also showed providing navigation services for persons who have serious high-risk conditions also has a positive benefit. So they created a set of HCPCS billing codes and a payment mechanism for principal illness navigation. And so this, under principal illness navigation, a person can receive health navigation services to address their serious high-risk condition, and the time spent providing that navigation is reimbursed under the codes for principal illness navigation. The personnel for that also include community health workers, health navigators, health coaches, and social workers. And then the far right column is principal illness navigation peer support, and that is limited to persons who have for peer support services, and it's for persons who have a behavioral health or substance use disorder. So organizations that have trained peer support workers, you can match those peer support workers with persons with a behavioral health or substance use disorder, and now that's a third pathway for reimbursement. And so CMS thought really very broadly in addressing the needs of the community. And then later in the presentation, I'm going to go into detail about the types of services that qualify for reimbursement under these categories. Next slide. So these are the HCPCS billing codes for each of the categories. The way that the billing codes work, and this is important context when I take you to the examples. And so I have them in the three categories: community health integration, in the middle, principalness navigation, and then the peer support last. So if we focus in on the top chart for CHI, or community health integration, you see that there's three codes. The first two are for traditional providers, and the third one is for FQHCs, or rural health centers, or federally qualified health centers. So first, I'm going to talk about traditional providers that are non-FQHCs or rural health centers. This is time-based billing. And so the reimbursement is for the time spent working on behalf of the beneficiary to address their social needs. There's a minimum threshold of 60 minutes that has to be spent before any billing can occur. So you see the first code for CHI that says G0019. So that G0019 could not be billed until there's 60 minutes of labor spent addressing the social need of the person. After the first 60 minutes, then the provider would bill for every 30 minutes after the first 60 minutes with another unit of G022. If you look at the reimbursement rates in the third column where it says the non-facility rate, that's where the vast majority of traditional providers will be billing under the non-facility rate. Under the non-facility rate, that first hour would reimburse at $80.56. For every 30 minutes after the first hour, you would bill another unit of G0022, and that bills at $50.26. So as an example, if I had a community health worker that's addressing food insecurity for a beneficiary, and they spent 2 hours in one calendar month. The time is allocated per calendar month, and you cannot carry time over from one month to the next month. You bill based on the total time spent in one calendar month per beneficiary. So that example that I had, we spend 2 hours addressing their health-related social needs. For the first hour, we would bill G0019. For the first 60 minutes, we would receive $80.56 for the reimbursement. For the second hour, we would bill 2 units of G0022, and that would reimburse roughly $100.50. So for 2 hours of community health worker labor, it's roughly $181 is the reimbursement for 2 hours of labor. And I want to point out a pretty significant thing in the rules. The rules specifically state that the time that's captured is time spent working on behalf of the beneficiary, not face-to-face with the beneficiary, because they recognize that you're going to spend time. If I think about housing insecurity, I may be spending time identifying where there's available vouchers, figuring out the process of getting in line for a voucher, assisting with applying. And while I'm working on vouchers, I may be looking at options in the shelter system. So I'm spending a considerable amount of time working on behalf of the beneficiary, but not talking to the beneficiary. This time, all of the time counts. And then the time is aggregated per calendar month and billed. One additional point. It's the aggregate of time spent per calendar month. So let's say I have a beneficiary who has food insecurity and housing insecurity. And I may have one community health worker that specializes in food insecurity, and I have another community health worker that specializes in housing. The housing community health worker spent 2 hours, and the food community health worker spent an hour. The aggregate of time is 3 hours. So it's not that I'm billing one to take away from the other. It's all additive. Let me see. I think there were some questions in the chat. Someone asked in the chat, can I clarify whether this reimbursement applies to both Medicare and for clients who have Medicare Advantage? I imagine it does. Yes. So it absolutely does. This is a benefit. It is a Part B benefit. And Medicare Advantage and special needs plans have a statutory requirement to cover all Part B benefits. However, the provider must be in network or paneled or credentialed with that Medicare Advantage plan. So you do want to make contact with that Medicare Advantage plan to ensure that the providers in network and the services are covered, but those plans have a statutory requirement to cover it, but they don't have a statutory requirement to contract with everybody. So just make sure that that is in place. Now, the methodology that I discussed to aggregate the time is the same for each category of codes: community health integration, principal illness navigation, and the peer support. Next slide. So now I'm going to provide much more detail about the concept of community health integration. Next slide. So key aspect of community health integration. Remember, this is the benefit to address health-related social needs. And so CMS was very clear in the rules that you cannot address social needs just for the purpose of addressing social needs. There has to be a direct link to the social need having an impact on the health outcomes you're trying to achieve, whether that's treating or diagnosing the condition. And so there has to be that connection. I give you the example of food insecurity. If I'm the primary care provider and I'm managing diabetes, and a person who has diabetes has food insecurity, and they report to me that they get most of their food from the food bank, and the thing that they're able to get most readily from the food bank is a case of oodles and noodles and Doritos, well, it's going to be very difficult for me to get that A1C down to 7 if their diet consists of oodles of noodles and Doritos. Same thing with, let's say I'm managing congestive heart failure, and the person says, well, I'm able to get a case of lunch meat and potted meat and crackers, and that's pretty much my diet. Well, that sodium intake's off the scale, and it's going to be very difficult for me to successfully manage their congestive heart failure. So you have to make the connection between the food insecurity and the health outcome we're trying to achieve. And that is the qualifying factor for community health integration. And that needs to be documented in EMR. Does that mean that only the provider can document the connection? No. Anyone that's on the care team can identify the connection between the social need and the health outcome. Next slide. So there has to be consent. One of the reasons that there has to be consent is because this benefit pays for time that's not face-to-face with the beneficiary, which is important because you want to be paid for all your labor. And because a lot of this labor is non-face-to-face with the beneficiary, it reimburses. But because it is reimburses for time that's not face-to-face, it's very important the beneficiary fully understands that we're going to be billing their insurance for these services, and some of those services will occur non-face-to-face, so that's why consent is required. And again, there has to be this documentation of the social need and the connection to the health outcome. Next slide. Each beneficiary must have a qualifying visit or initiating visit. Sorry, it's called initiating visit. So that initiating visit is the visit with a provider, doesn't have to be a primary care provider, where they document the connection between the social need and the health outcome, and then the fact that community health integration should be deployed. And again, just reiterating examples of the type of auxiliary personnel that operate under what's called general supervision, which means there just needs to be a general plan, expectations, and that the provider receives updates on the progress on addressing the social needs. Next slide. So another thing that was pretty significant in the rules is that CMS specifically said that in many instances, providers will not have the capability or the depth to fully address the broad range of social needs that are being impacted in the community. As an example, only 30% of the participants in the The 1 million participants that were in the accountable health community model I talked about earlier had all of their social needs met. And the majority of people had more than one need, with many people having 5+ social needs when they were fully screened. It is not expected that most providers will have a team of community health workers and social workers that they can immediately deploy to address the full range of needs, particularly when the people have very complex needs. So CMS wrote in the rule that providers could consider contracting with community-based organizations as a mechanism to have expert personnel in addressing social needs, to work with them for the population and use the payment mechanism to compensate them to make this model fully sustainable long-term. Next slide. Not only did CMS have the deference to suggest that providers contract with CBOs, they actually listed examples of CBOs in the rule. And so that, again, is very significant. So now you could go to a provider and say, this is not just a good thing to do, or it's not a good idea. It's actually in policy, and you can show them the policy where CMS said you providers should consider contracting with one of these. And not only did they list them all, but then they left a catch-all at the bottom where it said other nonprofits that perform social services. So you see there's a very broad range of suggested groups that providers contract with to deploy these interventions. Now, it doesn't stop a provider from hiring their own community health workers to provide these services, but I highly suggest that folks think about the aspect of the rule that says the aggregate of time. Like I gave the example where you could have more than one team member addressing the need. You could also have where there's time, maybe there's a community health worker embedded in the clinic who then screens and then passes off to a community health worker in the community that then extends the work to address those very complex needs in the community. Because we're billing based on the aggregate of time, all of that time is added together for the billing. Next slide. So this is the list of interventions that qualify. All of them qualify, and any time spent for any of these activities can be counted towards the billing of community health integration. I highlighted a few of them just to point out what I think is the significance of them. The first one, top left-hand side, person-centered assessment. So if that person is one screened by their clinician and identify that they have a social need, it is a very good idea to have that person re-screened by a trusted community member or community health worker, because the data shows when I'm screened in the doctor's office, I may not fully disclose all my needs. And so if I'm re-screened in the community, then I may disclose additional needs. And now the time spent doing the screening in the community is billed under that person-centered assessment. Now that I've done the assessment, right next to it, I'm now going to develop a plan that's person-centered to address their social needs. My time spent planning, fully compensated. Now let's take this example of I'm addressing housing insecurity, and I can assess, I developed a plan, and I got this person placed in emergency housing. Is my job done? No, because if I go to the far right column, health education, and most importantly, facilitating behavior change is reimbursable time. So think about someone who's had a history of homelessness. I can't just put them in an apartment and think, oh, well, they're going to do great. I need to address the behaviors that may impact their ability to stay long-term in that same apartment. And now my time spent each month facilitating behavior change is fully reimbursable time. And then the accessing community-based social services. And then for my hospital partners, on the far left at the bottom, highlighted, coordination of care transitions. So I have this person admitted to the hospital who now has housing insecurity. The hospital gets an additional 3.1% just for reporting that housing insecurity is there. And now there's a pathway for compensation to address the housing as part of the coordination of care transitions. Next slide. And again, just highlighting again that this is time-based billing, and the time-based billing is with no cap or limit. And so if that person needs 5 hours, you bill for 5 hours. You just have to make sure that there's a need, you documented that there's a need, and the time spent is addressing the need, and it does not have to be time spent face-to-face with the beneficiary. Next slide. Principal illness navigation. So just given the contrast between the two. Remember, the eligibility factor for community health integration was there had to be a social need. The eligibility criteria for principal illness navigation was that there has to be a serious high-risk condition that's expected to last 3 months. And if they don't have that risk addressed, then there's a risk of hospitalization or functional decline. Some examples of conditions that CMS listed as eligible criteria for principal illness navigation include things such as diabetes, heart disease, dementia, cancer. And so you can imagine a family who has a loved one with advanced dementia. And now the family is not sure they can continue to care for their loved one at home. And they need options. And now I can match that person with a navigator, and that navigator can assist them with finding the best options that meets their needs to care for their loved one with dementia. And the time spent supporting the family is fully reimbursable under principal illness navigation. So someone asked a question that I want to address. So just to clarify, the actual billing can only be completed by the provider. Yes. So that provider must submit the claim. They're submitting the claim based on the time spent of auxiliary personnel addressing the need. That provider has been recommended to consider contracting with community-based organizations who have the labor or the workforce that's the experts at addressing this. And through that contractual relationship, it will speak to, you're going to bill for these services, and that billing is going to be based on the labor of the community health workers provided by the community-based organization. And when that reimbursement is obtained, then you will compensate the community-based organization for the labor. So it just have to be that, and so that community health worker becomes a part of the interdisciplinary care team. But now there's a direct payment mechanism for their labor supporting the team. And that it carries the weight. So it's the same for each category of codes. So back to principal illness navigation, next slide. So the implementation is very similar in that there has to be an initiating visit. There should be this that initiating visit by an eligible provider, and that eligible provider, again, under the category of principal illness navigation, has been recommended to contract with community-based organizations that have the expertise in providing this service. The time is an aggregate, and it's an aggregate per calendar month. One additional difference here for principal illness navigation, included in the list of serious high-risk conditions that qualify, it also includes serious mental illness. And so serious mental illness, since that also qualifies for principal illness navigation, then the qualifying provider to do the initiating visit and to provide the supervision and billing was extended to include physician, non-physician providers such as a nurse practitioner or physician assistant, and a clinical psychologist was added. Clinical psychologist does not qualify for community health integration, but does qualify to oversee principal illness navigation. Next slide. Here's the list of activities that are reimbursable under principal illness navigation. And you see some of the very similar categories, things such as facilitating behavior change, even providing, if you look at the far left-hand side, facilitating and providing social and emotional support. Think about the family who are making end-of-life care decisions for their loved one, and they just need emotional support. Now that emotional support is fully compensated with no limit on the time spent. And so if you think about a provider trying to give emotional support limited to a 15-minute encounter, like it's not going to happen in a clinic setting. But now they don't have to. They can say, you all are having a very tough time, and I am going to link you with a trusted resource who now is going to support you beyond what I have the time to do. And now this support extends into the community. So now this emotional support is wherever the family needs or wants that emotional support. And it doesn't have to be face to face. So this could be emotional support over the phone, or maybe we're going to have a family care conference, or, Aunt Nina wants to call in from Washington State. And so we could have and discuss what to have. All of that's fully compensated under these new codes, and it's billed based on time per calendar month. Next slide. So now I want to give you a sample process flow that includes transitions of care so you can see the flow for our hospital partners and how this links to community. Next slide. So this is an example of a person admitted with a diagnosis of diabetes and a history of homelessness. And now that history of homelessness, remember, qualifies the hospital for an additional 3.1% reimbursement because homelessness is recognized as a complicating condition of their admission. So just by reporting homelessness, the hospital instantly gets additional MSDRG payment. And then linking that person post-discharge with a transition clinic that is partnering with a community-based organization that deploys community health workers that will address their health-related social needs, sets up a pathway for a fully sustainable model with compensation for all. Next slide. So I'm gonna walk you through this busy slide process flow, but it's numbered, and we're gonna start at the top left-hand side with number 1 and then go kind of clockwise around the wheel. And so this same person was admitted with, remember, diabetes and a complicating admission condition of homelessness that qualifies the hospital to receive an additional 3.1% in reimbursement. And then the discharge planner in the middle, number 2, refers this person for a transitional care management follow-up visit at a transition clinic that's partnering with the hospital. So then you go to the far right-hand side and you see I list examples of transition clinics that could receive the patient post-discharge to do the initiating visit to qualify for community health integration to address the social need of homelessness. The examples of transition clinics that could be considered include resident clinics. Some hospitals have transition clinics. Heart failure clinics are a good one. Obviously, FQHCs, rural health centers. Some hospitals are partnering with home-based primary care, and some are establishing chronic disease clinics that are run by nurse practitioners. So then we go down to number 3 is where the actual visit occurs. So the physician, nurse practitioner, physician assistant does a transitional care management visit with the patient. They identify that there's this complicating condition of homelessness, addresses the diabetes, and then tells the beneficiary, I'm going to obtain your consent and then link you with a community-based organization that hires community health workers that are going to work with you in the community to address your homelessness. So then item number 4, they make the referral to the community-based organization to deploy community health integration services to address the housing insecurity. You go over to number 5, and then the community health integration services are deployed. The staff, i.e. community health worker, health coach, social worker, begin spending labor to address the social need of homelessness. Each calendar month that they're working with the beneficiary, The meter continues to run with no limit or cap as long as we're working on behalf of the beneficiary and capturing the documentation. And then based on the total time spent per calendar month, we're billing, and then compensation comes in. And now the provider that's already compensated for their labor receives additional reimbursement for the community health worker labor, and then takes that additional compensation to compensate the community-based organization that's holding the labor of the community health worker. So all members of the care team are fully compensated in this approach. I also want to point out that there's something called concurrent billing, where some practices are deploying a service called chronic care management. And some of the practices on the line are familiar with that benefit. I want to point out that the rules allow for concurrent billing. So during the same depiction I have here, the provider can bill for transitional care management for the post-discharge medical visit. They can have clinic staff do chronic care management and be compensated for chronic care management, and concurrently bill for community health worker labor doing community health integration and receive compensation for that. So again, all members of the care team are fully compensated in this approach. Next slide. So now I want to walk you through a case study so you can see the actual documentation requirements and the integral part of the documentation requirements, so that it will take some time to engineer the process flow. Next slide. So this is a real case study of a site that I helped implement this. So this is Gertrude. Obviously, the pictures are fictional and the names are fictional, but it's a real case study. So Gertrude, 62-year-old female, history of bipolar disease, homelessness, and diabetes. She's had multiple ED visits for uncontrolled diabetes. She reports difficulty storing her insulin. She's insulin dependent. She also reports difficulty adhering to the recommended diet. Because the staple at most shelters, and she spends time in shelters, breakfast is usually what? Juice and muffins. Juice and muffins doesn't necessarily fit with a low carb, low sugar diet for a diabetic. And so, but if that's all she has to eat, she eats it. And so this is a real case. And then she also has great difficulty storing her insulin needles and glucose test strips. For those that aren't aware, insulin needles are hot commodities in the shelter system, and they're often stolen by people who have problems with addiction. So all of this makes it very difficult for Gertrude to manage her diabetes. Very complex situation, but real life for many people. Next slide. Gertrude sees her primary care provider. So the primary care provider on the screen assesses Gertrude and documents in the record. Not only does Gertrude have complications related to her diabetes, she has complications related to her health-related social needs. So you see the direct connection between the social needs and the health outcomes. And now the clinician is documenting in the problem list housing insecurity, transportation, poor health literacy, and inadequate medication adherence, all complicating social factors that limits the ability to manage the diabetes. So you see the connection made between the social need and the health outcome in the EMR during the visit. Next slide. So the provider then documents the diabetes treatment plan. The ultimate goal, maintain the A1C below 7. In order to maintain the A1C below 7, we have to improve her diet. We have to get her compliant with her medication. She has to do daily glucose monitoring, and she has to get back to the primary care provider once a quarter for A1C testing. All of that's complicated by lack of transportation, lack of housing, and lack of stable food. Next slide. So the provider says, I'm going to get consent and I'm going to deploy a solution for this complex problem. My solution is contracted with a community-based organization that's deploying the community health worker. So our community health worker on the screen contacts the primary care provider, gets an understanding of the needs. Does a plan The time spent developing the plan is billable time. The plan is I'm going to apply for housing assistance. I'm going to talk to the shelter to see if they can come up with some special accommodations that meets her dietary restrictions. I'm going to come up with a transition plan. I'll try a transportation plan, and I'm going to make sure we're coordinating with the other members of our care team, i.e. her psychiatrist. So just the time spent discussing and developing the plan is the first set of billing. Next slide. And remember, this planning is not necessarily face-to-face planning with the beneficiary. Now that I have the plan and I've talked with Gertrude about the plan, I'm implementing the plan. My time spent implementing the plan is reimbursable time. So some of the interventions that we deploy, the community health worker deployed, I'm going to look into an emergency voucher. So I'm going to contact the local continuum of care. I identify the local continuum of care through the HUD exchange, identify them, I contact them, find out, do you have any emergency vouchers? What's the eligibility criteria? If there's a waiting list, how do I get on the waiting list? My time talking with them is all billable time because I'm working on behalf of Gertrude. Now that I've started to address her housing, I have to revisit her food. So I'm going to contact the Emergency Food Assistance Program at USDA, and I found out that Gertrude, she never signed up for SNAP benefits. I now assist her with signing up for SNAPs, educate her on the use of her SNAP benefits, and making sure she uses her SNAP benefits in a way that aligns with her recommended dietary requirements. And remember, health education and facilitating behavior change is also reimbursable benefits. So it's no good for me to get Gertrude SNAP and she spends SNAP on oodles and noodles and Doritos, right? So I need to make sure that we match up her SNAP benefits with her dietary restrictions. And I may take Gertrude to the grocery store and help Gertrude with menu planning and say, Gertrude, you know, you're going to get $150 in SNAP benefits. How can we stretch those SNAP benefits as far as possible and still help you meet your dietary restrictions? And also, Gertrude, you need to learn how to read labels because we want you to be on a low-fat diet. And so I'm going to help you understand how to make choices that align with a low-fat diet. So I'm going to help you learn how to read labels, and we're going to go to the grocery store and do that. All of my time spent is now reimbursable. So think very broadly in the application of these benefits to treat the whole person needs. Next, I'm going to make sure that Gertrude remembers to take her medication. So we're running out of time. So I'm going to speed up. So let's go to the next slide.
Oh, we're not running out of time. Sorry, that was just me clicking too fast.
Okay, I think I hit all of this. I hit all the points that I wanted to hit. So we can go to the next slide. So it's important that the community health worker provides feedback to the care team on their progress. And so there should be this bi-directional feedback where they're providing updates on their progress. Next slide. The documentation requirements. So this is the important part. Every encounter where the community health worker is working on behalf of the beneficiary must be documented in the EMR. And so that documentation, the critical elements of the documentation are listed at the bottom. The start time, the stop time, the total time per encounter, and then the time is aggregated per calendar month. So I spend time talking to the emergency food bank. I do a note where it lists the start time and the stop time and what I did. I talked to the voucher program. I capture that. I then review that with Gertrude. That's a third note. Every single activity is a note. If I didn't document it, I didn't do it. It did not count. So every intervention must have those particulars, and it needs to list what I did, and it needs to match the goals I'm trying to achieve. Next slide. So this is the financial analysis, and this is what I really want you to take home. This benefit is really to be meant to take to scale. The analysis that CMS has done, particularly if you look at dual eligibles, those persons who have both Medicare and Medicaid, it's estimated that over 80% have one or more social needs, and all of them have this benefit on the books today. So if I have, for example, one community health worker supporting a caseload of 50 patients, the caseload is not important, but what's most important is when you start looking at the math is what I call the production time. So that second bullet, let's say that if I set an average expectation on production for my community health worker team, where each community health worker is supposed to work towards a target of production where 60% of their time is spent providing billable services, where 40% of their time can be spent doing non-billable services, such as relationship building, resource finding in the community, just working in community, doing non-billable tasks, establishing relationships. As long as 60% of their time is providing billable services, this is a hypothetical model, business model to look at. Obviously, from a management perspective, you could probably get more than 60% production, but this is for illustrative purposes to show the impact of scale on these benefits. So again, if I have a 1.0 FTE community health worker, that's 160 hours per month, that's 40 hours per week. If I look at that from a lens of 60% production, that would mean that 96 hours per calendar month would be billable time. 64 hours a month would be non-billable downtime, lunch, travel, talking, meeting, relationship building, non-billable time. Now, can that be sustainable with only 60% production? I believe it is. So now let's look at the reimbursement. If I take that first reimbursement code, G00019, remember it reimburses at $80.56 for 1 hour of community health worker labor. And again, if I take 60% production, that would give me 96 hours of billable time. Once you do the add-on codes, remember the add-on codes, an hour of the add-on bills at $100 an hour. So I'm taking worst case scenario that I get no add-on and I'm only getting a base of an hour. For 96 hours per month, that reimbursement would be $7,733. So if I look at the table across at the bottom, if I take the salary of a 1.0 FTE community health worker, and I took the National Labor Statistics median salary for community health workers to come up with that number, where the national data shows the median wage for community health workers is $25 per hour. So if I have a 1.0 FTE community health worker making $25 an hour, I'm paying my labor costs for 160 hours per month is $4,000. Now, if I add in 35% fringe, which is a little bit higher than the national average, but if I add in 35% fringe, then that's another $1,400 per month. So my labor cost, my labor expense, salary plus fringe, $5,400. Now, if I compare that to my gross revenue, at 60% production, my gross revenue is $7,733. So my net at my net at 60% production is $2,333. Now, for purposes of scale, and I know this doesn't include things like travel and other things, but the purpose of this exercise is really to show the impact of scale. Now, if I look at the far column, if I have a team of 10 community health workers, all working at 60% production, using the same metrics, that would net $23,000 per month, and that would equate $280,000 per year, only at 60% production. And so that's one way to think about how to take these services to scale in a sustainable manner. So I know I had an hour, so I'm right at an hour. Do you want to switch to questions? Do we have time for questions? I'm not sure what the agenda is.
Yeah, we have time. Tim, if you want to continue, you can continue. We'll still have until 11:30 for questions and discussion if you want to just wrap up your presentation.
Sure, I'll jump right in. So Sherry asked a question at the bottom. So in my experience, what amount of the funds billed to Medicare are kept by the provider organization in order to fund administrative billing costs and or the program management? Great question. So what we have been advocating for is for most providers have outsourced their billing, and they've outsourced their billing to a third party. Then most of those third parties take a percentage of claims. And in most instances, that percentage of claims is something south of 7%. Many people are like 5%, 6.5%, some 7%, almost nobody's at 10. So what we've been recommending, and I've gotten a lot of buy-in, and many practices have started to implement this, is that they will keep 10% of collections for administrative costs to file the claims. And then 90% that's left is a pass-through to the community partner because they have real labor costs in the community. And so that is a way that to begin a negotiation, acknowledging there's some administrative costs on the provider side, but there's real costs on your side for labor. And so that's why acknowledging the administrative costs and having a pass through the community is a good place to start.
So Tim, you would recommend ensuring that if community-based organizations are working with a provider, that they ensure that their contract includes more than just the base salary of the CHW, but includes those additional costs to the provider who's billing.
Yes, so you definitely should consider that and have that as part of your negotiation, but you want to get as much of the labor reimbursement coming back to the community-based organization because you have the labor costs. So you want to get as much as that reimbursement, but also acknowledging that there is some administrative costs. Now, in that negotiation, they may, and this is something that's actually happening, they may look at the reimbursement and say, well, $80 for an hour, I'm sure you're not paying your community health worker $80 an hour. No, but you have administrative costs, you have G&A and overhead and fringe and other things that you have to cover, as well as the other thing that is inherent in working with community-based organizations is you have a built-in mechanism to manage a team of community health workers, and that management team comes with its own costs. And so, yes, you're providing supervision, you're providing outreach, you're coordinating your community health workers, and so you need that additional buffer in the reimbursement to cover for that additional expense.
Janet Gonzalez had a comment in the chat, worried that with a limit of 60 minutes plus 2 times 30 minutes may not be enough time in a given month. What has your experience been? Now, Tim, I don't believe there's a cap of 2 times. Is that correct?
Yeah, I'm glad. So I gave the example of 230 minutes and a base of 60, just for illustrative purposes to show how the money is calculated. But the beauty of these rules is that there's no cap or limit per calendar month. And so the meter continues to run as long as you're addressing the need. And so so I've done this presentation with CMS multiple times where we give the example. If you spend 5 hours, bill for 5 hours. You spend 6 hours, you bill for 6 hours, because these are complex needs. And so it is time-based billing without a cap or limit.
Yeah, Tim, we got another question from Puerto Rico, who wanted to inquire if there's any information available regarding whether Puerto Rico can claim this benefit or for CHWs through the physician rule change.
So this is a benefit that does include Puerto Rico. Now I know Puerto Rico has some limitations on benefit coverage. So when I did pose that question to CMS, and they did say it is an active benefit that also includes persons who have Medicare that reside in Puerto Rico.
Thanks for that, Tim. So, and participants, if you have questions, please raise your hand and we'll be happy to unmute you so you can ask your questions moving forward, or you can type them in the Q&A box so that we could keep track of them to have them in our FAQs that we send out after the webinar.
While we wait on additional questions, I did have one more slide that talks about implementation barriers. So I'll go ahead and go through that, and then feel free to post additional questions. So we can go to the next slide if we still have time. So things to consider prior to implementation. There are some barriers, and then there's some solutions that I want to give you if you hit those barriers in talking to providers about this. This is a Part B benefit. Hospitals bill under Part A. Outpatient providers bill under Part B. So there must be this connection with an outpatient provider. That's why in that process flow, I showed the connection between the person being discharged from the hospital, discharge planner, connecting that person to an outpatient clinic. The outpatient clinic bills Part B. So establishing that relationship with the outpatient provider. And some of those examples include hospital-owned practices, transition clinics, resident clinics, FQHCs, and we're seeing a lot of that where hospitals, remember, they're mandated to screen for social needs. So they're finding a glut of people with social needs, can connect those persons to an outpatient clinic who now can trigger billing to address the social needs. Cost sharing. You may hear from providers say, it's a Part B benefit. Beneficiaries have out-of-pocket costs that they are required. So that is true. Medicare Part B, Medicare pays 80% of the allowable cost. The beneficiary is required to cover 20%. That 20% is the technical term for that is co-insurance. It's often called a copay, but technically it's a co-insurance. And so you may say, well, that is a barrier for persons accepting this benefit if they're going to have to pay 20% of the cost. Well, on the right-hand side, the second bullet, the data, the most recent data, 2024, from the Kaiser Family Foundation, their analysis shows that 95% of the Medicare eligible population has a Medigap secondary policy that covers the out-of-pocket expense. So the population that do not have full coverage, we're talking about 5%. 95% do, including dual eligibles. A person that is dually eligible for Medicare and Medicaid is 100% insured. And so that is a great place to start because dual eligibles have a greater likelihood of having complex social needs and complex medical needs. It does require that initiating visit. I explained that connection there. Because of the requirement to document the social need, to document the connection between the social need and the health outcome, as well as the bidirectional exchange of information between the community health worker and the provider, that does require some changes to the process flow. I recommend the third bullet in the solution side. Start with initial pilot to establish the process flow. That once we establish that process flow in the initial pilot, then we have a proof of concept, then we're ready to replicate that new process flow to the larger patient population pool. So I've worked with, large practices and I explain all the things that have to happen and they close their eyes and they say, we can't imagine re-engineering the entire process flow for 100 physicians serving 10,000 patients. And I'm not asking you to. Let's start with one provider. And even let's say you can take a smaller than that. Let's start with one provider in one location. And let's start with 10 patients from that one provider to get the process down. And then that solves two problems. One, that gives us a proof of concept, and that gets us some patient champions who experience the process to talk about their experience, and it gets us a provider champion to talk about their experience. Then we go on a road show to the rest of the providers talking about how we can have a measurable impact on their clinical practice the same way we did with that one provider. So that's a way to get people to move, because sometimes we get paralyzed by the paralysis of analysis about how we're going to do all this work. Let's just get started, because the need is there. It is well documented the need is there, and now there's a payment mechanism to address the need. And then lastly, folks being not sure how to identify the priority population to get started. And I, again, continue to recommend that if you're thinking about a priority population to start with, always think about duals. That the dual eligible population, again, they're fully insured. Those are persons enrolled in both Medicare and Medicaid. And 80% based on the data have at least one social need. 60% report having complex medical needs and comorbid behavioral health conditions. And so now, remember, that person is eligible for addressing their social needs. They're eligible for support for their behavioral health conditions. And all of the time spent is fully reimbursable with no limit or cap per calendar month. And it's time working on their behalf in community settings, on the phone, all fully compensated. So where can you find additional resources? We have set up a website where you can find additional resources and information. On this website, I have sample contract between a provider and a community-based organization and in that sample contract, it outlines the 90% flowing to the community-based organization, with 10% being retained by the provider as administrative costs. And so that's fully available. It is a live contract. I have that contract active in multiple markets. So it's one that is in use and it's available. All of these resources are available for free on this website. There's no pay window or anything. And feel free to share that resource with anyone who has questions. We also have some of these webinars and other things that we've done. And there was a primer document that I did with CMS, kind of introducing providers to these billing codes, and that is also available on that website. Someone said, David said that the ratio of 1 to 50 for the community health worker, the patients, is much lower than I expected. So that was just to give a basis, because I hear a wide range of community health worker caseloads. And honestly, I think that community health worker caseloads should be adjusted based on complexity. So the more complex the population, the lower the number of patients the community health worker have. If they have a lot of low complex patients, they could have a higher number. So that number fluctuates. What's most important is adjusting the caseload side to get to production. So if we focus on, am I optimizing production time? And if I set a base of 60% production, as long as we're driving 60% production and they're meeting the needs of the population, I really don't care what the caseload size is, because I want outcomes. And there's money to drive outcomes. So if I can keep the caseloads moderate and hit the production, if there's more patients, I hire more community health workers, because the money's there to add team members instead of adding burden of super large caseload sizes.
All right, so I think that's our last slide from Tim. So we have Tim's contact information is on the slide, and we will be sending out the recording as well as the slides from this amazing presentation. But while we have Tim on the line for the next 15 minutes, if you have questions, please let's utilize this phenomenal resource for our region. I know we have some hospitals on the line. I know we have some clinics that are doing work with CHWs. We have the DC Primary Care Association that's working with federally qualified health centers, Children's National Medical Center is on the line. Ask your questions now. So we have a question from Dewan. Does CMS recognize that CHWs are a type of provider or auxiliary members? Does that make a difference in billing, or does that matter?
So excellent question. So for purposes of these codes, the community health worker, remember the codes are not limited to community health workers, but the community health worker is one eligible type of auxiliary personnel. They are not an eligible provider type, which means they cannot bill independent of the provider, but they are through general supervision, they are recognized as a person on the care team and their time is captured in the billing. But the billing goes through the eligible provider, which for community health integration is a physician, nurse practitioner, or physician assistant. For principal illness navigation, that extends to a clinical psychologist in addition to the physician and non-physician provider.
Now, go ahead, Tim.
I was going to say one more thing about community health workers. So I often get this question about scope of practice. And training. So in order to provide these services, the person, whatever their position is, have to be adequately trained to perform the function. And they have to work within their scope of practice. If there is not a defined scope of practice, let's take the example of community health worker. In many states, there's not a specific certification requirement for community health workers. And so absence of a specific certification requirement for community health workers, then the person providing the service must be operating so they don't infringe on someone else's scope of practice. So I'll give this example. I'm a community health worker and I'm operating in a state that does not have a certification for community health workers, but I've been trained as a community health worker. That is fine. I now am deployed to work with a person who has housing insecurity and they're up for eviction. I go to meet with the person and I'm addressing their housing. While I'm addressing their housing, they start speaking about how they're severely depressed. And now I'm the community health worker. And I state to the person, based on your description of your depression, I think you are clinically depressed, and I'm giving you a diagnosis of major depressive disorder. I have now infringed on someone else's scope of practice, and that's beyond the expectations of a community health worker. So I have to stay within the confounds of a community health worker, and I cannot infringe on someone else's scope of practice. And so that's the way to think about whether that person is self-declared as a health coach, community health worker, navigator, social worker, whatever you self-declare yourself as. If there is not a license or certification requirement within your state, you just have to be adequately trained and you can't infringe on someone else. I.e., if I'm not qualified to make diagnoses, I can't make diagnoses. If I'm not qualified to do wound care, probably shouldn't be doing wound care. I should call the nurse to do the wound care. That's the way to approach it. So you don't have to have a certification unless the state mandates a certification for whatever position you self-declare yourself as.
So for
someone
example,
said that the
New York,
certification in Virginia is voluntary. It's only if it's mandatory. If it's a mandate in the state, then you have to meet the mandate in the state. If it is not a mandate in the state, then you have to show that you're adequately trained and not infringe on someone else's scope of practice.
yes, thanks for clarifying that, because there are some states that don't have CHW certification and are fine with that, and that is a perfectly acceptable qualification for CHWs to be reimbursed through this physician rule as well. We had a question. In your experience, the model of CBO clinic, is it well accepted by clinics, or do they prefer to hire community health workers directly? And I'm going to add on to that. What have you seen as a best practice for getting clinics or hospitals or those providers to partner with CBOs?
Yeah, so best practice. I go right to the data. So the largest demonstration we have on screening and addressing health-related social needs is the accountable health community model. And I would show them that evaluation report. There's a link to the evaluation report in the slides. And in that evaluation report, we screened, we, the United States, through this demonstration, we funded the screening of over 1 million beneficiaries for health-related social needs. The vast majority of that population who had navigation services did not have their social needs resolved after a year. 70% did not have all of their needs resolved, but they still had a reduction in the total cost of care. So if I look at it from that lens, and I'm working with a clinic, a transition clinic, a hospital, and they have some community health workers. And those community health workers are working with persons, many of which the data shows are going to have more than one need, some of them with 5+ needs. This is not something that's real quick where we turn it around really fast and then we go on to the next person. Many people are going to need support and assistance for a year or more. So you could hire community health workers in the clinic, but to fully address the broad range of needs, the best practice is both and. You hire some in the clinic, they get started, then they hand them off to me, and then I continue to support that person in the community long-term until all of their needs are fully addressed. So that frees up the limited number of community health workers in the clinic to continue to churn. And so I was working with a large ACO in the state of Michigan. And that ACO was looking, accountable care organization, and they had members in their ACO across the state. And they estimated in order to fully address the social needs amongst their population, they would need 100 community health workers. And the ACO was like, you think we're going to hire 100 community health workers? And then what would the management look like to manage 100 community health workers? They were like, no, we're going to hire maybe 10. And then we're going to contract with as many community-based organizations as possible and let them bring on the 90 to get to the scale we need to address the broad range of needs. And so that is what we're seeing emerge as a best practice. And I'll give you one more example. I was working with a large integrated health system, and this large integrated health system had like 700 beds. So it's a 700-bed hospital. They had like 60,000 ER visits every year, and they had 15 community health workers. And so they were like, we're gonna keep our community health workers active. I said, you got 700 beds, 60,000 ED visits. You got 15 community health workers. Like we're tossing water in the ocean there, right? So they're gonna need a both and to get to scale to address the broad range of the needs. And so that is the approach that is going to make this work long term.
Thanks for that. We had another question. Any insight on integration of these codes into state Medicaid programs?
Yes. So we are actively advocating. I was so pleasantly surprised. I was doing a presentation with the Chief Transformation Officer for Center for Medicare, and he repeated what I've been advocating for, is that state Medicaid, as many state Medicaid offices are thinking about new 1115A waiver authority and in lieu of service authority, that all of those requirements from the Centers for Medicaid and CHIP require state proposals to include billing codes for interventions to address health-related social needs. The beauty of these services is CMS created permanent HCPCS codes that are not limited to Medicare. So now there's a clear set, first of its kind, HCPCS billing codes specifically for addressing health-related social needs. So as states think about new 1115 waiver authority or in lieu of service authority, we're advocating for them to simply adopt the blueprint that CMS has already established for addressing social needs. And when they do that, they can use all the evidence that CMS already put together to create this benefit and then adopt it under new 1115A waiver. And then that gets us to multi-payer alignment between Medicare and Medicaid. And an example that's close to this, but not exactly, we're still waiting. So within the state in your region, right? So DC, for those that aren't tracking, on I think it was June the 6th of this month, they submitted their 1115 waiver application to CMS. It's available on the CMS website. It's pretty long, but it's a good read. And in their application, DC, oh, someone said, could I define HCPCS code? So HCPCS are billing codes. It's a form of billing codes similar to CPT, but they are regulated by CMS, and they are official billing codes that all payers can adopt. And it allows a payer to have a provider bill those codes and receive reimbursement. But back to, thanks for someone putting the actual definition, what HCPCS, the words stand for. So DC submitted its 1115 waiver application on June the 6th. Very good read. DC, the way that process occurs, they submit to CMS their proposal for an 1115 waiver authority. CMS reviews that. CMS often comes back to the state and says, we reviewed your application. We may consider approving it with changes. They almost never accept it as is. So then there's this negotiation back with the state Medicaid office and CMS until they come to an agreement on what CMS will allow and what the state wants to do. Then once that's approved, then the 1115 waiver is approved for implementation. What's nice about what the proposal in DC states is that DC is proposing to create a new health-related social needs benefit and health-related social needs case management that will be reimbursed under Medicaid. So now we have alignment, potential alignment, where DC is proposing under the Medicaid program, we're going to pay for screening for health-related social needs, and then we're going to pay case management to address their social needs. And guess what? DC proposed to pay for that under Medicaid up to age 64. Because when you get to 65, you can use community health integration. So it just flows right across the continuum of the lifespan, where we have alignment, where there's compensation to address the health-related social needs. Now, there's obviously, they just submitted that, so it's a long way to go before that becomes an actual benefit, but that's an example of states thinking innovatively to come up with a model. So I think it's also important for you to advocate to Medicaid to adopt these same strategies as an aligned payment model.
Awesome. We also had a question, will this recording be available? Yes, it will be, and it will be sent out after the webinar is complete. Any other questions? Tim, my comment was just that with DC Medicaid, we've asked that CHWs be included as language specifically related to that case management. But because CHWs aren't recognized in the Code of Health Professions in the district as yet, there's still a lot of work to go there, but our goal is that we will have alignment between Medicare and Medicaid as we move through the 1115 waiver implementation, hopefully soon.
Excellent. Excellent.
Any other questions? So I guess, Tim, in our last 2 minutes, just a general, if you were a CBO, like who provides community health workers services to individuals in community, what would you recommend CBOs be doing to prepare to be attractive partners to a hospital or that has a part A billing or Part B billing or the ability to partner with these clinics?
So you absolutely know your value. So there's evidence that shows that your interventions have a direct impact on readmissions, unnecessary ED visits, and hospitalization. And based on that evidence, there needs to be compensation for your work. And so, but you need to state the value, share the evidence, and talk about how not this is a nice to have or a good thing to think about, but how do we get to brass tacks and start piloting this out? Because there's a clear pathway to reimbursement. There are a lot of providers that don't follow this as closely. I mean, I often say to people, like, I'm in a bubble. I talk about this all day, every day. And then I go place and they're like, what? I never heard of community health integration. And I'm like, I fall off the map when they say that, because I can't believe anybody hasn't heard of this, but they haven't. And so we need to share the information with them and then talk about how we can start implementing, and then also help those providers think about honing in on a priority population. And I work with a lot of ACOs and hospitals, and they're always crying the blues about certain populations: dialysis, behavioral health, substance use disorders, dual eligibles. Those are easy priority-based populations that no one is going to say, yeah, we never have problems with those groups, right? They all have problems with those groups. And now there's a payment mechanism to do good, to address the needs on people who have complex needs. So I think that, like, honing them in on a way forward with compensation for your work, it should be the next steps.
Awesome. Thank you so, so much. I think that brings us to the end of the webinar. Tim has his contact information on the slide. If you as an organization would like to speak with him to learn more about the technical assistance services of Friedman's Consulting, please reach out. And as always, IPHI is also here to facilitate conversation and connection as it relates to CHWs. Thanks for joining this Z Turner Center webinar. Thanks so much to Valerie, Kelly for coordinating, for Taya, and of course, thank you, Tim, for your time today. Have a wonderful day, and we look forward to working together to get CHWs sustained in our region. Thank you.
You.